So I think if it's okay, we're going to go ahead and get started. Um, Welcome, everyone. We're so happy to see everyone for our final Research Nexus presentation of the year. Thanks, Deb, for all your hard work in organizing our Research Nexus program. We so appreciate all the effort that you put in for us to support this program. I'm going to go ahead and share my screen. I'm Ann Spolarich. I'm professor and assistant dean for research, and I'm the co-director of the Center for Oral Health Research within the Still Research Institute. And joining me today is my colleague and frequent partner in research studies here at ASDO, Maureen Perry, who's professor and associate dean for advanced education and strategic partnerships. And we're excited today to talk with you about our experience in conducting research in special populations. So we've set some learning objectives for today. We want to take a few minutes to talk about some common health conditions among individuals who have disabilities. We'll talk about some challenges, including obtaining informed consent and assessing decision-making capacity and assent. We'll also talk about some challenges that we've encountered in terms of planning and study implementation and evaluation of outcomes. And we'll share some lessons that we've learned through conducting research with individuals with disabilities and special healthcare needs. So that is our plan for today. So Dr. Perry, I'm going to have you pick up from here.
Okay, thanks so much, Ann. So according to World Health Organization, there's 3 dimensions of disability. One is impairment, which is a person's body structure or function or mental functioning, so like loss of a limb or vision or memory. There's activity limitations, such as when people have difficulty seeing, hearing, walking, problem solving, and participation restrictions in your normal daily living activities, or we might call them ADLs, right? Activities of daily living. So things like working and engaging in social and recreational activities and obtaining healthcare and preventive services. So a disability can be a variety of things. So it might be present at birth and can affect your functions later in life. So again, like vision, hearing, mobility, cognition, and it can be genetic, or it could be from, teratogenic maternal exposure. We might also see developmental conditions. So we think about things like autism, ADHD, so developmental disabilities. It might be related to an injury. So you might have been fine and then have an injury later on in life, like traumatic brain injury. It could be a long-standing condition that gradually gets worse, and we see disability like vision loss or nerve damage, limb loss, and things like diabetes, right? So where patients end up with amputations or progressive vision loss. And then we see things that are progressive, like muscular dystrophy, or you might see something static, like once you've lost a limb, then it's gone. Intermittent, like MS, right? And we think about categories of activities and participation. So things like, can you learn and apply knowledge? Can you manage tasks and demands? Can you get around? Can you manage self-care tasks? So your activities of daily living. Can you manage domestic life? Can you live on your own? Can you handle a house? Can you pay your bills? Can you establish interpersonal relationships and interactions and things that are appropriate and socially acceptable? Can you engage in education and employment and money and finances and things that are major life activities? And then again, community, social, civic life. Can you participate in the community? And disability impacts every one of us. There's 61 million people in the United States, adults with a disability. And so that's like 1 in 4. So if you think about it, we have like 20 people signed up here. So you're looking at 5 of us with disabilities. I can sign up right for that right now. Got my own, right? Percentage of adults with functional disability types. So looking at the major areas of disability. And this kind of just shows you that mobility is is the biggest one, and followed by cognition and independent living. And that's not really a surprise given the amount of people that we see with Alzheimer's and the number of people that we see living longer. So that kind of makes sense, right? And we see it, right? So the longer you live, the more chances that you will become disabled, okay, but still beats the alternative, right? You're still living, so got to look at it that way. 2 and 5 above 65, it's more common in women, and it is, you can see here, 2 and 5 non-Hispanic, American Indians, Alaskan Natives. So again, looking at it from the standpoint of healthcare disparity, right? Chronic diseases, so 6 in 10 adults have a chronic disease in the United States, so that's more than half. For those of you doing the math in your head, that's a lot of people, right? And 4 in 10 adults in the US have 2 or more chronic diseases. And so we look down at the bottom and we see things that often go together, right? We see things like heart disease, stroke, kidney disease, diabetes. You often see those all together, chronic lung disease, cancer. So the leading causes of death and disability and the leading drivers of our $3.5 trillion in annual healthcare costs. That'll wake you up, huh? Love that number. So about 50% of 57% of deaths and 42% of disability adjusted life years are lost in the US. And they're attributable to the top 10, right? So high body mass index, tobacco, dietary risk, blood glucose, blood pressure, drug use, alcohol, high LDL, kidney function impairment, and occupational risks. So when you look at ourselves and our patients, yeah, it's pretty common, a lot of lifestyle things there, right? And so adults with disabilities are more likely to be obese, smoke, have heart disease, and have diabetes. We certainly see that in the populations that we see. You don't usually see one of these things without some of the others. So if you have a chronic disease, it's going to increase the likelihood of having missing teeth and poor oral health. Why? Because if you look at this, a lot of these are like compliance issues, right? So if patients are sort of non-compliant in one area, not really taking good care of themselves, they're likely to be non-compliant in their oral health. For patients who have weakened immune systems, such as patients with HIV or organ transplants, they're also at a higher risk for some specific oral problems. And of course, if you have a chronic disabling disease like TMD, autoimmune disease, or osteoporosis that compromise your oral health and function, we see that most often among women. So folks with developmental disabilities, right? So when we think about a developmental disability, that's something that happens before the person becomes an adult, right? So developmental disability happens before you turn age 22, according to the federal government, right? So when we think about developmental disabilities, we think about intellectual disability, epilepsy, we think about autism, and cerebral palsy. So those are kind of like our big four. There are other ones, but those are our big four. So when we say developmental disabilities, that's really who we're talking about. A lot of cardiac disorders in this group, particularly people with Down syndrome. They have more MVP, they have more ASD, they have heart valve damage. They have a lot of GERD, and we see this in cerebral palsy, certainly. And the thing with GERD is that some of our folks aren't able to tell us they have GERD. So imagine you are nonverbal and you have some gastric reflux and people keep feeding you, and boy, you know, you keep acting out because you don't have a choice about being fed and you don't feel so good. Not a great situation. We think about patients with seizures who maybe have, we often see this with people who have intellectual disability and other developmental disabilities. We see seizures and people might have a poor gait, and they end up having anterior teeth chipped and they bite their tongue or cheeks. And then of course we see other impairments like hearing and visual impairments. These folks are often have latex allergies more often than other people. And that's really due to the fact that they've had a lot more medical interventions. So we start, but now that we don't use so much latex, that's a better thing, right? So we don't see so much of that anymore. Again, 1 in 5 kids have a chronic illness. So let's, not forget that impacts everyone, right? So if we have a child who has a chronic illness that's sort of like impairing the entire family, right? Because this is a kid who needs all the help and has to go to all the appointments and maybe has to go to a special school and maybe costs a small fortune to have somebody intervening for this kid. And then also don't forget about all the massive amount of medical care, right? So very expensive. Oral health problems. So we see a lot of decay, we see a lot of periodontal disease, we see malocclusion, right? We see some damaging oral habits. So we see, sometimes we call it self-injurious behaviors too. We see people who it's like skin picking, or they pick their gingiva, or they might ruminate and things like that. We see all sorts of different things going on with teeth and malformations. So too many teeth, not enough teeth, funny shaped teeth, things like that. We see teeth that don't come in on time, that are delayed. We see lots of trauma and injuries from people with a poor gait or seizure disorders. So, the relationship between oral health and behavioral health, oral health has an important influence on people's psychosocial health, right? So if you have poor oral health and it leads to toothache and anxiety, ADL, impairments, impaired social interactions, they may not eat correctly. And then don't forget, it's a very social thing to have front teeth, and people, we kind of judge people who don't have front teeth, right? We look at them and we say, boy, what's going on with that? Or we might make an assumption about a person, and that might be a conscious or unconscious bias about someone who doesn't have front teeth. By the way, many of our people who have intellectual disabilities couldn't care less whether they have front teeth. They're just living their life and they don't care what you think about them, which, you have to think about that. It's maybe a healthier mental place to be. I don't know. When it comes to self-image, right? Self-reported health by people with disabilities. It's interesting because they're more likely to report poor general and poor mental health. And even though we will, stratify, the disparities are still there even if we stratify by level of education. But then again, don't forget, these are people who can actually self-report, right? And we're going to talk about this a little bit later. So these are people who are high functioning enough to understand the question and report on themselves. Significant differences in risk factors and preventive behaviors. So smoking, obesity, physical inactivity, lower rates of preventive screening. Right. So what if you have an adult patient who says, well, I don't want to get that screening? What are we going to do about it? And more difficulty accessing healthcare services. So where you and I might say, oh, we have to go for whatever test, we might just say, well, we're going to get in our car, we made an appointment, we're going. And that may not be how this person gets around town. They may have to, get an accessor ride. Someone may have to drive them. Maybe they're not even their own guardian. So lots of problems related to accessing healthcare. Again, what kind of barriers and what we would call working age adults, right? So we think about that 1 in 3 adults with a disability does not have a PCP, doesn't have a healthcare provider. They might have an unmet healthcare need because of cost. So many people are covered by Medicaid, or here in Arizona, that'd be Access, right? So people are covered under Medicaid, and maybe they can't afford if there's a copay, or maybe it's something that's not covered. And that's, again, 1 in 3. And then 1 in 4 of people did not have a routine checkup in the past year. Well, I would tell you that it's probably way higher than that. I would say the last 3 years, right? Because of COVID, we've had many people who haven't had any kind of checkup, can't get a checkup, would love to have a checkup if they could find someone who has time to check them up, right? So lots of problems in that arena right now.
Yeah, we've certainly observed that in our own patients, that's for sure.
Yeah. So again, we know that there are health inequities between people with intellectual and developmental disabilities and people without, right? And for patients with IDD, the disparities are tremendous, right? So we know that it's harder to get healthcare. When it comes to oral health and IDD, I can tell you that it is the hardest thing to get. It is the greatest unmet health need of people with IDD is oral health care. they're vulnerable to poor oral health, and because they're more complex to deal with and they have probably other comorbidities, it's a more challenging situation. Why do we have these disparities? Well, we talked about some barriers. There's a need for assistance, right? So sometimes people can't even brush their own teeth. We always ask patients, like, who brushes your teeth? Do we have supervised brushing? In other words, someone watching you, or are you doing it on your own? I always ask patients, can you show me how you do it, right? So we have those big giant teeth here in the clinic and a big giant toothbrush, and I say, show me how you do it on there, and then show me how you do it in real life. Let me see how you're able to do this. So we have behavioral challenges. People might be like, I just don't want to brush my teeth, and I'm an adult and you can't make me do it. That kind of stuff is a little bit difficult. We might have communication challenges where patients really don't understand what we want them to do. We have a high prevalence of patients with G tubes, right? Enteral feeding, patients being fed directly into the belly. So that's a problem, right? Because there's nothing breaking up in the mouth, and we're not necessarily always, I think caregivers sometimes aren't worried about oral health when they think, oh, well, they're not eating by mouth. It's not a big deal. It turns out to be a bigger deal than you think. And there's a higher likelihood of having lower educational and income levels when compared to people who don't have intellectual disability, right? When we look at the impact of prevention, so being physically active and eating healthy foods and not getting too much sun, and get regular checkups, and don't smoke, and use your medicine, not drinking or drinking in moderation if you have substance abuse, and then staying in touch with family and friends, and if you need help, to ask for it. These are things that might really be challenging for people with intellectual developmental disabilities, right? Especially if they live in a group home, this might be challenging. They might not have control over a lot of these things. They might not be in touch with family and friends. They might just not be in, really, they might not be the masters of their own destiny every day. They might not be able to go out for a walk. They might not choose what they get to eat. They might not choose if they're out in the sun. So all of those things are really impactful. And then really what is the health impact of not having these? Or what if we were able to get good preventive interventions? And that's a fantastic opportunity for research. And we really haven't seen a lot. These folks have not been included in these kind of preventive studies. So.
Yeah, it's why we have chosen to dive into this area of prevention, certainly as it relates to oral health. But I realize we have so many of us joining in our session today who are working in other health related professions. But we always like to take an opportunity to remind everyone of how oral health is really such a big influence in other aspects of people's health. And I don't know about you, Dr. Perry, but I think we've seen so much in terms of if somebody's not taking care of their mouth, like you said, there's something else that's also going by the wayside. So we can see certainly a lot of patterns and trends. So we thought we'd share with you some things to be thinking about if you're interested in conducting research in special populations, and share with you some of the tips and lessons that we've learned along the way for some really practical application of this knowledge. And then we're interested in having some good discussion with you next. So just to remind everyone, in 2018, there were some changes to the common rule. And of course, our IRBs here at ATSU were so helpful in communicating those changes to us. But one of the things I thought would be important to review today is, who do we consider to be vulnerable populations? And essentially what we're really talking about here is people who are vulnerable to coercion or undue influence. And I always like to kind of focus in on this word coercion a little bit. It's a very strong word to use in research, because the implication is if you're coercing someone, there is the intent to do harm. And obviously, for all of our human subjects, not just for our patients and individuals who are vulnerable, we always have to design our studies to make sure that we are doing everything in our power not to coerce individuals. And we also have to consider undue influence. And I think this conversation comes into play when we talk about the use of rewards, or how well does somebody really understand what a potential benefit might be for participating. So if you take a look at this chart, it's a nice little chart where we had our previous definitions of who were considered to be vulnerable populations before the revision of the common rule. And what you see now is a little bit of a change. And we now include individuals who have impaired decision-making capacity. And this, of course, is a pretty big encompassing term, because while we certainly in the past might have considered someone with a mental disability, someone with an intellectual disability, we now know there's other individuals who can have times of impairment with their decision-making capacity. Maybe it's under severe emotional duress, for example. We were talking earlier today, Dr. Perry and I do a lot of research with individuals who are newly diagnosed with cancer. And so many times when we're seeing them, first of all, they're still reeling from their diagnosis, and then they're referred to see us, and they're a little blindsided by even needing to come to a dental department for evaluation. It wasn't even on their radar, and they're in information overload, and they're dealing with a lot. And we have to take that into consideration if we're going to be talking with them about a study opportunity that they might like to participate in. And are they really in a place where they can make a good decision about giving informed consent? So, of course, when we look at the common rule, the IRB has to determine that any type of time we design a study with a potentially vulnerable population, they have to determine that we've all met certain kinds of requirements. And this is just a good reminder for everyone. And the idea is that you do everything in your power to minimize potential risk to the to the subject. So the first thing is that whenever you can, that you use procedures that are consistent with sound research design and don't unnecessarily expose people to risk. And whenever possible, to try to use procedures in a study that are already being performed on the subject, either for diagnostic purposes or a part of treatment. We also want to make sure that the risks are reasonable in relation to the anticipated benefits, and that the importance of the knowledge that may be reasonably expected to result as a part of participation in the study. We also want to ensure that selection of subjects is equitable. So that means the IRB takes into account the purpose of the research that's being proposed in the setting where it will be conducted. So the IRB has to be particularly aware of special problems of research that involves people who are vulnerable to coercion or influence. And that, of course, includes children and prisoners, individuals who have impaired decision-making capacity, or people who are economically or educationally disadvantaged. And that informed consent has to be sought from each prospective subject or the subject's legally authorized representative. Now, there are other criteria that go along with this decision making on the part of the IRB as well, but this kind of hones in on what we're focusing on today. So NIH has spent a considerable amount of time revising some of their requirements for funding in a proposal. They want to really now see that the investigator has applied the ethical principle of equitable subject selection, but that we have to be thinking about, it doesn't require that in order for someone to participate, that an individual who is least impaired would be sort of the ideal candidate, if you will. In other words, we don't want to restrict our reach for recruitment and enrollment to people who are the least impaired individuals. And I think in the past, we've certainly seen that happen. And the problem is that you lose the opportunity to see how a condition can progress and change over time. So if you only study the mildest or earliest cases of a disease or a disorder, well, that can be important in and of itself, depending on what question you're asking. It isn't likely to give us a lot of insight into the development of more severe symptoms and the associated disabilities that result as that condition progresses. And that can also include someone's impairment of their decision-making capacity. So Dr. Perry brought up a really good example of this is Alzheimer's disease. So somebody's decision-making capacity at time of a new early onset diagnosis is going to be very different from how it might be in the later stages of the disease. And it is important also to understand the underlying biological mechanisms under which conditions, disease symptoms will worsen. And that information, of course, is important as a driver for improvements in diagnosis and treatment. And to also keep in mind that research that doesn't directly benefit the individual might be of benefit to family members or other at-risk individuals who either are at risk for developing it or they already have the condition, but maybe it's in a different stage, but also society as a whole because it advances our overall knowledge and understanding of the disorder. So when you apply for an NIH grant, you will find all of this information under their policy and compliance tab. And I would encourage you to kind of take a look at this because they have a whole section on research that involves individuals with questionable capacity to consent and what are some of the things to consider. So consent capacity is really refers to somebody's ability to understand the information that's relevant to making an informed voluntary decision to participate. And, these would be things like what's the purpose of the study? Is it experimental in nature? Risks versus benefits? That the person has the right to withdraw or even choose not to participate. Are there other alternatives for that person if they choose not to participate? Protection of their confidentiality and what kinds of safeguards are the investigators putting in place to minimize their exposure risks. But then we also have to think about and remember again that there may be other kinds of conditions like neurological disorders. Somebody has a stroke, or maybe they're taking medications, for example, that are psychoactives and can have some central nervous system effects. Maybe people have a history of substance use disorder. The way they may present at initiation of treatment may be very different a year down the road once they've gone through treatment. So we have to recognize that in some situations, while their condition may actually produce some kind of very meaningful impact of impairment of their capacity, other situations it may not be as significant, right? So it's very individualized. And because of this, assessing consent capacity has become a little bit of a challenge. So as a result of this really policy for federal funding, but I think for any kind of funding or study you're designing, it's important to be aware of the fact there are lots of tools that have actually been developed over the past decade that look at how to assess someone's decisional capacity. The challenge is that there isn't really a good consensus about, one that's the standout. I think they've been used across so many different disciplines. This is actually a really good systematic review that we wanted you guys to have that looked at 23 different instruments that are available to assess decisional capacity. And then when they went through their search criteria and they narrowed the terms, 6 instruments focus solely on understanding the information that's disclosed to the potential subject, and 11 tests for understanding, appreciation, reasoning, and expression of choice. So they vary a lot in terms of the number of items, the flexibility of the item content, and how they're scored. So I would encourage you, if you're doing work with a a vulnerable population who, you're concerned about whether or not they have good decision capacity, to do a search and look through and find some of these different tools. There are a couple different systematic reviews that are out there, and they're also based in the application of these different tools in different populations. And I think it's really informative to try to just be aware that they're out there, and to do a little bit of a deeper dive on your own, in your own discipline and in the population you're going to be working with. But I also like to give you some practical guidance. And actually, UC San Diego, on their IRB site, has what I think is really, really helpful guidelines that they developed for their UCSD researchers. And it's all about decision-making capacity guidelines. And they talk a lot about different kinds of situations like cognitive impairment, but they also talk about where people may have severe pain and anxiety, or they may be confused, or they're experiencing a major life event like a new diagnosis of cancer or a life-threatening illness. And they talk a little bit about some of the things to be thinking about and give a nice set of guidance. So from that site, they define decision-making capacity as a potential participant's ability to make a meaningful decision about whether or not to participate. And a decision-making capacity is thought to include at least the following 4 elements. So understanding, which is the ability to comprehend disclosed information, and you can see some of the information that falls under this category. Appreciation, can the person appreciate the significance of that disclosed information and how it relates to potential risks and benefits in that individual's own situation and for their own condition? Reasoning is ability to engage in a reasoning process about risks and benefits and participating versus alternatives. So in other words, they can sort of weigh what their options are, and the ability to express a choice about whether or not to participate. So how is this different from competence? Because it should not be confused with competence, which is a legal term. So incompetence is a legal determination made by a court of law. And while a court might consider information about a person's decision-making capacity when making a competency determination, they're not synonymous and they don't mean the same thing, right? So someone may be legally incompetent to make financial decisions, but they still could have enough capacity to make meaningful decisions about whether or not they want to participate in a research study. So decision-making capacity is protocol and situation specific. So I would really encourage everybody to hop onto UCSD's IRB website and to read more about this, because it was really informative to me, and I thought it would be a nice help for everybody. So we want to just take a couple minutes now to share some lessons learned with some studies we've done here in our Advanced Care Center within ASDO. And all of these studies are IRB approved. And we're not going to talk about really much of the results of the studies. We want to talk about some things that we had to think about in the design of these studies. So the first one we wanted to share with you was a study that we conducted in individuals with intellectual and developmental disabilities who had self-reported dental anxiety, who were coming to receive a comprehensive evaluation in our clinic. And we were actually interested in looking at some physiologic stress metrics to see what would be the effect on stress biomarkers if we used animal-assisted therapy as the experimental intervention. So we actually assessed for different biomarkers in saliva. Cortisol, for example, was one of them. And then we also had the subjects in this study rate their mental health scores and their anxiety scores before and after animal-assisted therapy. So we used a convenient sample of 10 pre-screened patients, and they were randomly assigned to dental treatment as usual. So how we would manage those individuals like we typically do. And the people who were in the experimental group were people who got to have a registered therapy dog present during their appointment. So they could, you can see on the pictures, they could either hold the dog on their lap, or they could have the dog in the room right next to them, even within reach. So we used a validated state trait anxiety inventory questionnaire, and standard procedures in terms of vitals and collecting saliva samples before and after the intervention. Now, what was so interesting about this was that it's a big decision to use an intervention like this with an animal, because there we were concerned that people might feel that they were being excluded if they saw somebody else get to have time with the dog and they didn't, because of course we had to have informed consent. So they knew that there was a chance that they wouldn't get to be picked to have time with the dog. And in somebody with an IDD, the challenge is, of course, that it's difficult for them to understand what could become a very emotional feeling of being excluded, making them feel marginalized, and being upset. And we certainly don't want to do that for any of our patients. Now, other investigators published in the literature, they tried to do other things, like the control group got a stuffed animal to hold as opposed to an actual animal. And what we decided to do instead was, if you were a subject who was assigned to the control group, what we did was we finished the whole appointment and did all the study interventions. And as soon as the last intervention was done, then we allowed that person to have time with the dog so they could play with the dog and pet the dog and hold the dog. And we did that to reduce their feelings of exclusion, because again, you have to think about the emotional impact of this study. So a little bit of an ethical decision for us, because we didn't want people to perceive that they were being harmed by being excluded. Um, we did another study, which actually the first study of its kind, where we wanted to assess whether individuals with special needs could actually recall that they were given educational information about their oral health and how to take care of their mouth. And we also wanted to know what these individuals wanted to have in terms of additional education about oral health. And so the purpose of this study was threefold. We wanted to assess their basic knowledge. In other words, if you have a toothache, what should you do? How often should you brush your teeth? Did your dentist teach you how to brush your teeth? Things like that. And then we actually also wanted to assess their perceived value about their oral health and the value of actually receiving oral health education, and have them help us to identify what additional educational needs the patients wanted to have. So we had 203 subjects in this study who completed an 11-item questionnaire. So because these were individuals with intellectual and developmental disabilities, we had to get consent from the legal guardian for the person to participate. We also had hoped to be able to get the same information from the person who was most involved in caregiving, if that person's disability required having a caregiver on board. So we actually offered this survey on an iPad, and we also did it by using the iPad and reading the questions to individuals who had a challenge with reading. But first we had to figure out whether or not they were actually able to answer the questions to participate. So we used another validated screening tool called the St. Louis University Mental Status, or the SLUMS exam. And in order to become eligible, you had to correctly answer 3 out of the 5 questions, and you can see them there. So knowing the day of the week and the year and what state we were in, they had to be able to correctly identify which shape was a triangle, and of those shapes, which was the largest. So 3 out of 5 in order to be eligible. So We actually learned that many people were able to complete the survey on an iPad, which was wonderful. We didn't have a tremendous need for investigators to help with navigating the iPad. Some did require the investigator to read the question and answer choices. And of course, the challenge with that is there's a risk for parroting. So, if I might say to you, did your dentist teach you how to brush your teeth? The respondent might say, the dentist taught me how to brush my teeth, right? Parroting back. And so it becomes very difficult to know if you planted the seed of what the response might be. And like I said, we also tried to get caregivers to complete the same survey to see what their perceptions were about the value of oral health education and how well they perceived the person they were taking care of, their ability to recall this information. But what we found was that if we did the survey with the patient first, the caregivers got a little annoyed with us because there was a lot of extra time spent listening to the discussion, or watching how much time it took for the participant to go through the iPad. So at the end, a lot of the caregivers declined to participate, and so the lesson learned is it might have been better to have the caregivers working on that survey, and we always waited till the end of the appointment to do the survey with the patient. So timing is everything, and sometimes you don't learn these lessons until you actually try to walk through it. So Dr. Perry.
This is an old study. It's actually the first study I did here when I first got here in Arizona to ATSU, and I did it with Allison Snyder, who's now Allison Valier, and Kurt Bay, who's still Kurt Bay, and Maureen Romer, who's now Maureen Perry. And I think Eric Sowers is still himself. But obviously life changes for me and Allison. So it's an old study. But it was pretty cool because what we wanted to see was about oral health related quality of life, and health related quality of life, and to look at whether asking caregivers and asking patients if patients and caregivers were kind of on the same page. Now, this has been done in a lot of other populations. There's studies with people who have had strokes and people with dementia and people who've had cancer. And for those groups, the caregivers and the patients were kind of on the same page. So it was fairly reliable to ask a caregiver for some of those folks who had illnesses. And when you ask the patient, it was a pretty good dyad. They seem to be on the same page. But we really didn't know when we ask a caregiver about the health and wellness of a patient, do they really know? Is it predictable? Was this useful? Right? Which is kind of funny to think about because we've been doing it for years. Like we ask someone else, how does this person feel? And we actually thought that was real. And as you're going to see later, turns out not so much. So we just assumed that people were on the same pair. So we had 53 consecutively sampled dyads of adult patients and their proxies, right, their caregiver. And we used the SF-12, which is it's the short form of a questionnaire about quality of life. And we used the standard oral health impact profile. And it was all during one visit. The thing that we did with this is that we actually had a single investigator who was like one of our research. Actually, he was trying to get into medical school. He's long since graduated from medical school, but he actually was our research assistant, and he interviewed every single one of the patients. So he actually read it and he interviewed the patients. And we did that because we were trying to control for bias and what one of us might say to a patient to explain a question versus another person might explain the question differently. So we were trying to remove that from the study. But again, the parroting can be an issue. So they were explained in the same way. When we looked at the results, what we basically saw that patients reported better scores than their counterparts, right? So the patient and proxy reports were somewhat correlated on some of the subscales, but the thing was that the patients distinguished physical pain from emotional problems. They were like, well, my teeth was different from how I felt about my teeth. And the proxies just reported it as one big problem. Like if they had a tooth and they were complaining about it, that was a single issue. So what we really saw was that there was really not a lot of correlation. So that the patients really were more positive, and they were more complex in their ideas about their oral health and had more ideas and more things that didn't necessarily correlate on the subscales than the proxies. And what really happened was the more the patient was impaired, the better the patient felt they were doing. They're like, I'm totally fine. So the patient was sort of more disabled. They were like, yeah, I feel good. My life is good. My health is great. And my oral health is great. Whereas if they were more impaired, their caregiver or their guardian said, well, no, actually, they're not so great. And vice versa. When patients were less impaired, they felt that they had more problems than their proxies felt they had. So it was really interesting because that's sort of very different from the proxy reporting in other studies. So we did, this was before the SLUMS was there, and we tried to use this, which is actually a questionnaire from Pfeiffer, and it's really used for geriatrics. It's a much better tool. So we tried to find different tools, and in the end, we modified this to just be questions 1, 2, 3, and 5. So like, do you know if patients could get the date, the month, or the year? That was fine. If they could tell us the day of the week, the name of the place, and then how old are you? We tried this with the D2 students, and they actually couldn't answer question 8. Nobody knew who I was like, well, who's the president before him? We literally had students who couldn't answer that. So we said, well, if the students can't answer it, we don't think this is a great scale. So very interesting, right? So sad but true. Again, risk of parenting. There was we let the caregivers do it on their own. So the caregivers actually read it and filled it out, whereas the patients actually, you know, they weren't filling it out themselves. Of course, we also noticed that if the caregivers, you know, if they had negative feelings or there's a risk of bias about their own oral health, right? So while they're supposed to be thinking about the oral health related quality of life of the patient, there's always that risk that as they're filling it out, they're kind of throwing in what they think about themselves. So that's part of the problem with the proxy. And then again, our caregivers could not accurately report the patient's status at all. So that makes it more difficult as we move forward in thinking about whether or not, you know, can we rely on proxy data? Probably not. So again, to that question, historically we've studied problems that we're comfortable with and we intuitively understand. Why do we like to stay in our comfort zone, right? Studies are difficult to implement because of the control, right? We just talked about all the controlling factors, and should we not do stuff just because it's hard, right? So now we know it's hard. It's hard because you can't just ask someone else. You really do have to ask the person. How do we get the funding? So now NIH and some other people are giving us more, you know, people are realizing this is a population that needs to be studied, that deserves to be in big studies. And can the study be completed? And then can the study be published? If you find this stuff out, where are we going to publish this? Are there journals that are willing to publish on these special populations? And then of course, qualitative studies. And the problem in dentistry is that there aren't a lot of qualitative studies. Now, I know in some of the other fields, I've spoken with some of our colleagues, particularly over at ASHES, and I know there are other fields that do more qualitative studies. In dentistry, that has not really been embraced so far, and probably qualitative studies might be a better way to go with this group because it's hard to get a huge N of people, right?
Yep.
Another thing is that, you know, there's a huge movement about nothing about us without us. So why should we be studying about a group without having them being really being participants. There, there's not a lot of surveillance data. Traditionally, these folks have been left out of the big data sets. We can look at the NHANES data, all these other kind of data sets. There's no people with IDD in these. Is there an unconscious bias, or is it just too difficult to get the data? Is it just too hard to ask them the questions, so we don't bother? And why do we think of this group as a special population? Like, isn't everybody a special population, right? If you're doing a study about patients who have diabetes, not a special population. Like, don't we always look at special populations? So why don't we look at this population? And the research that's been done is really not patient-centered research. So I think to have the discussion, you really need to get some people with some disabilities and do some focus groups about, like, what kinds of things should we be looking at? What kinds of things should we be asking people? What's important to this population? How can we advance their health? So things to really think about.
Yeah, great discussion. So I'm going to go ahead and stop sharing, and we'll see if anybody has any questions for us.
Dr. Schlossman, no questions? I think one of the things that Ann and I really started, we had a really great discussion when we were talking about this, getting this ready. And one of the things, it's like, we realize people don't do it because it's really hard. These studies are really difficult, and they're hard getting the IRB, and then it's hard collecting the data. And these people also, don't forget, they really do have a burden. The caregivers and the patients already are carrying a lot of burden. So for us to be like, hey, can we ask you some questions? Can we test you? Can we book? Can we prod you? It almost feels like we're adding to that. And we kind of have to get out of that mindset. We have to realize that if we want to help these populations, we need to get better data and research, because we just don't have it. And it's like we have surveillance data on like everyone except this group.
Well, and I was thinking too, it's so hard to get papers accepted where, things didn't go as planned, or maybe you have really negative findings or went in a different direction, which happens a lot in these kinds of studies, especially when you're trying on a new methodology and a new population. And there's research anyway, there's always something you don't anticipate. That's what I've learned my life lesson. But I think there's a value to publishing what worked and what didn't work, so that other investigators can learn, hey, we tried this, it wasn't so great. And next time, this is what we're going to learn. And I think that's a culture shift in terms of publishing, and really finding the right fit to share this information and to disseminate it is really critical. So we really thank everybody for being with us today.
And one thing, it's okay for me to say one thing.
Sure.
And because I saw when Dr. Perry share her research, I saw you use SLAM. So in my program we also use SLAM from St. Louis University. So actually, but of course we use for the different population. So we are not doing the research actually. So we're doing it's not research. It's just doing some kind of therapy when we use and also for our students to use the SLAM. So.
Sure.
So just quite interesting. So, yeah.
Right. And again, it's sometimes you have to try different screening tools to see based on the population, like really what's the best way to do this, because it's quite labor intensive to figure out. And in a clinical setting where you only have so much time, where the patient's in front of you, you have to be efficient too in figuring out, is this person eligible, and especially if to capture something in the moment, right?
It is. So, of course, we focus on geriatrics, of course, on seniors and so on hair. And also we use a tool for our students to use hair. So, by the way, I'm not in Arizona, I'm in Missouri. So we are used to that too.
Thank you for sharing that.
Yeah, I think of the one study that we had done a few years ago with the detention center. They were, as a different type of a vulnerable population,
right?
Juvenile detention center. So, and that we were able to work with the IRB because it was more of an assessment type of a situation, as opposed to a separate type of a study where we were doing things other than we might normally have done. And so that goes back to what you said early on in the presentation about trying to keep things in line with what you would routinely do. Because I know when we first looked at that, we thought we've got 2 strikes against us already, and yet it worked out well from a pilot standpoint. So
Right.
a different kind of a vulnerable population, certainly.
Yeah, it's a great point. Thanks for sharing that. And it's a lot to navigate. And there's additional safeguards, certainly, if you want to work with a prison population too. So, yeah, we're a little fearless. We kind of dive in and and try on these opportunities for size. So, well, thank you everyone so much for joining us today. And thanks to the Nexus for giving us this opportunity. We really appreciate it so much. Thanks, everyone.
Yes, thank you.
Thank you.
Bye.